I think you can see pretty significant recession on the first premolar and also on the lateral incisor, and a significant recession on the central incisor as well, and maybe a little bit thin on the right central. So I'll point to all those as we do. I'll show this around here. Let's see with gauze, and I'll just wipe that down just a little bit. See a little bit better. The significant recession is here on the premolar, a little bit of recession on the second premolar, also a little bit on the canine, quite a bit on the lateral incisor, and at least 3 millimeters on the central incisor, and maybe a millimeter in thin tissue on the right central. So we'll graft those teeth. It'll be 1, 2, 3, 4, 5 teeth, 20 through 25. 19 is good. If you can see 19, it has a good zone of attached gingiva, no recession, so that's ideal. Good zone of attached gingiva on the second premolar. But the first premolar has a little collar of tissue that's completely unattached. And then thin tissue with a collar of unattached keratinized tissue on the canine. And the same thing, collar of keratinized tissue but unattached and a little inflamed on the margins on the lateral incisor. And it looks better here, but there's no attached gingiva if you look closely on the central either. And there's a frenum here that will go under, and thin tissue and shallow recession on the other central. There's some plaque in various places. If you look right here, you'll see a little plaque. So the first thing you want to do is clean everything. And I just left this here to show you so you see what you may encounter. So we will just go through and make sure that everything is perfectly clean. I'll use a curette and floss. And from a position in front of the patient, I can reach the distals of the right side and the mesials of the left. Patient has a fixed retainer, fixed orthodontic retainer that makes flossing a little bit more of a nuisance. But anything to have straight teeth, right? Okay, so now we're going to floss those teeth and follow that with EDTA. So this is kind of a boring part to watch, but an important step to perform. If you were to do an intracellular incision, you would drive a lot of bacteria into the pouch, quite obviously. So we want to remove all of the plaque as well as freshen the root surfaces. There's not a lot to do to these root surfaces, so I don't necessarily need access. I don't need to use the Vario 750 or any type of ultrasonic or burrs or anything of that nature. So we just go through tooth by tooth. Carefully clean out the sulcus. And I may block your view from time to time. But once again, I think you know how to clean teeth. I believe you have to learn how to do that to graduate from dental school. And I'm getting part of it from the position I'm sitting in, which is behind the patient's head. And I'm going to shift to a front position in just a second to get more of this and get it a little bit better. And I believe this retainer is only attached at the canines, so we can thread through one spot. I know this, once again, this is very exciting part to watch. But once again, it's also very important that you clean all this as well as possible. And now we will use EDTA solution to further cleanse this area and to remove any smear layer we created on the exposed roots. And we do an application of 17% EDTA with a Q-tip. And this takes place for 30 to 60 seconds. So if I don't have a lot of advancement to do on this second premolar because the recession is shallow, therefore I don't have to do extensive inclusion of the tooth past it. Really this second premolar dissection gives me mobility for the tooth that has a significant recession, the first premolar. So you have to understand why you're doing the different steps. So if this tooth were not to be included with the graft, I would still mobilize all of this tissue in order to advance the tissue at the first premolar. But I want to include it because there's shallow recession, there's not much. And I think it's a good idea sometimes to extend the graft past a tooth that has significant recession, to actually extend the graft as well. So including this premolar, I think is a good idea for a couple of reasons. But it's not necessary from a standpoint of lack of attached gingiva. So you might ask, why not just coronally advance this tissue? In other words, free it, but not include a graft there. And it's not unreasonable. I think it's okay. But on the other hand, I think that we will have a better outcome with augmenting it, and it just means trimming the graft a little longer. It's not a crisis. If I were in a position where I really couldn't include that tooth with the graft, that's okay. I just think it's a little bit better to include it. So it's not critical to the treatment plan decision process. So this is the instrument that I described to you that has really nice shank angulation, a narrow, thin instrument that slides into the sulcus well. And I'm just simply passing it using two different directions here so you can see it, into the sulcus and separating the attachment from the base of the sulcus to the crest. And I expect maybe osseous dehiscence in that region, so I was feeling for it. I think you can see it a little bit better that way. We want you comfortable as a primary concern. So anything at all that bothers you, tell me, okay? So we work our way around the sulcus of the canine, a little bit of an osseous dehiscence. And we've completed the canine, so I go to the lateral incisor. And I like, maybe you notice I'm getting the proximal sometimes before I get the midfacial, just to make it a little easier access, less tension on that thin tissue. And then I'll switch the instrument, so if you see the angle of the shank, it just gives me a little better access, and just gently engage that osseous crest. I don't feel any dehiscence here. And now to the central, and turn to your left tiny bit. Perfect. Our patient is relatively young, about to graduate from college in a few days, is that right? So from a very good school, he went to probably one of the best schools in the country, because it's the same school I went to. Southern Methodist University right here in Dallas, Texas. I'm pretty sure, I'm not positive, I think it's called the Yale of the South. But this is the curved elevator, and the curved end of the micro elevator. And we can use it typically with the curve down. That's the way it's normally used. So if we went into an area like this, you can use it like that more or less there, but it stretches the margin. So it's a little better, I think, to come in with the curve facing outward. I can't show you that. Let me see where I can. As I turn that way, it really come above. Let's see if I can do it this way. So if I bring the instrument in like that, you see how the instrument curves away from the tooth, but the tip of the instrument is parallel to the tooth. Then I can roll under that tissue. That show pretty well?
Yes, that's good.
And not disturb the margin much. There's very thin tissue on the facial aspects of these teeth, so I'm going to try to mobilize the papillary regions first. So I take some of the tension off of the facial aspects. And come to the midline now. Is that showing okay?
It's perfect. Good.
I just swing around that tooth a little bit. And now I'm actually entering the sulcus of the lateral. I made a little separation there so I can get under this papilla, distal to the lateral. But once again, I don't need to advance the tissue on the central much. So I don't need as much dissection on the tooth away from the teeth I'm treating in this case. If they all had recession, it would be different. We're going under that frenum. Looks like there might be an undercut here. So I'm going to see if I can turn this with a curve down and engage that undercut area, because I've mobilized the margin a little bit. And you should notice that I really withdraw the instrument slowly. You don't want any sudden movements. I may block your view here a little bit. Tell me if I do.
It's good.
And that's where I'm going in. You won't see that, but as I roll back, you can see lift under that tissue. And we, of course, expect an undercut, mesial and distal to the canine. Doing well.
Mm-hmm.
You get to any basketball games this year?
Mm-hmm.
Wow. SMU has Larry Brown as their basketball coach, and he is phenomenal. And they had a pretty good year. Could have done better in the tournament. But that happens. Now, sometimes I'll use the straight end. This is a spot I might. And just try to work toward that second premolar a little bit. There's kind of a wide papilla, as you see here. So just want to loosen some of that. And now I'll move to the second premolar. And if you'll take your time with this blunt dissection, the rest of it will go very quick and easy. And making some progress. and pretty well to the mesial root line angle of the molar there, well under this premolar. You're getting a nose job at the same time, you notice that? Use the thumb rest on the nose. So we're pretty good on the premolars. And we should potentially have an undercut here. It's not bad on the canine at all, maybe not one, but I still am suspicious of it. There is one right here. I'm not sure I can show that to you. Right there. A little dimple there. Do you see when I move it? I think it shows up a little bit more. So I'm going to come in here. Try to get past it slowly. I need to free up a little bit coronal to it. I think we're good coronal to it. And this mesial aspect. So right there is a part that's a potential undercut, and I'm going to try to use the curve down. And stay in tight contact with the alveolar process, work my way past it. It feels like I'm pretty well past it. Just a little bump there is what I'm hitting a little bit. I think we're good. Can you help me with the light just a little bit? Better. Thanks. A tiny little undercut or bump or something at this lateral incisor. I think you see that dimple on the canine area as well. There's just a little something catching a little bit there. And just running into a little bit of rocky road under here. We're really pretty good. Sometimes I can reach this midline, the mesial of the left central, easier from an anterior positioning of myself. In other words, I'm approaching the patient from in front of the patient instead of behind. And I already freed this papillary region when I was behind. Curve facing down now, again, a little bit. And just a little something hanging up right there. There's this undercut there. Pretty well past it. And I'm going to move around to the front again and check it this direction with the curve facing downward. And this is a matter of expect the unexpected. I'm really running into more undercuts in the incisors than at the canine. And this is after telling you to be careful of the canine. And again, it's just it's not always 100% what you expect. I pretty much like everything, except not thoroughly happy with this. And I'm not happy with this part right there. So I'm going to come around from the front and use the curve down to engage that area. A pretty serious undercut there. I'm going to try to get over that way a little bit from the opposite central, curve down. So I've mobilized enough of that margin that I can do this. Other direction here. We're pretty good. There's a little tag there. I think I can get that with the Orban here in a moment. But our next step is going to be trimming the graft. And we need to measure the site for the graft. I'm using a probe, and I'll measure from the root line angle of the molar. And there's 11 millimeters, 22, so about the midpoint of the canine, 33, and 44 gets me to the midpoint of this papilla. So 47 would be ideal, so we'll see what we find with the graft. And you see where the graft is soaked in the first dish, which is here, and that has a paper backing that's come off of the graft. Paper backing is typically on the basement membrane side, so if you want to identify it, you can. Then it went into a second soak, 10 minutes in each, at least. And the second one has a tetracycline in it. I believe we're using minocycline now. And that arms the graft with some antibacterial activity so it can defend itself the first few days. We try to prevent contamination, but you always can have a little bit. So I'm going to remove the graft from that wash and lay it on a gauze that's on a Hufredi cutting plate. I'm not sure what they call it, but I like that term. And I can show you this graft over here a little bit. It's a nice graft. This is the connective tissue side that's a little shinier and dimpled. And you watching that? You might see that one better. This side is a little bit more of a, I call it a suede look, and that's the basement membrane side. So let me just flip that so you can see them both at once. And that might be a better way. But you'll see this in the workshop and can tell the difference. And you can see it has a nice thickness as well. Let me position it better. So you can see the nice thickness it has, about 1.5 millimeters. So this little cutting plate has marks on it, and we can see that this graft is 5, 10, 15, 20, 25, 30, 35, 40, 45 plus. So I know that I wanted about 47, so I want the full length. So I'm going to put that back on the gauze to actually cut it. You'll have these plates, I think, in your kits in the workshop. And if I'm doing a lower, I want it about 7 millimeters. 7 to 8 is okay. And let me turn this just a little bit. I know the length that I need, so I just need to have the vertical dimension. So I'll use a 15 blade to trim it. I'll use my probe. And this is a 3, 6, 8, 11 probe, so there's the 7 mark. We're just really close to it. And just guide that blade through the graft. And I will have a piece that hopefully is about 7 millimeters dimensionally, vertically. Looks like we're pretty close to it. And now then I'll transfer this graft. Isn't that good looking? And there's again the connective tissue side, basement membrane side. I will transfer this to the PRP, platelet-rich plasma, and it will soak in here for at least 2 minutes. So I'm going to use a Younger Goods 7/8 curette as a curved elevator. And the idea is to go into the sulcus of a tooth. I've already separated it, the tissue from this tooth on the proximal of the lateral and the canine. So I can go into that sulcus, curve over to the lingual surface, then stay on top of the crest but under the soft tissue. So I'm doing a little bit of a sweep like that. Show you that again. A sweep like that. So I come in here, go under, and that way I'm just showing you that's mobile. You don't want to lift the papilla. This is not a lifting, it's a separation. So we want to disengage the papilla from the crest without tearing it. And that allows it to move coronally. I don't need to do this one really because we're not moving that much. Turn toward me now. I'll do the distal of the canine because of the premolar and the distal of the premolar. You don't necessarily have to do both sides of the papilla because if you go over the crest, you're just separating it from the crest. So that's the papilla separation. And now we will do the extension of the pouch. Make sure we have a patent pathway for the graft. So just drop in the sulcus. And it works a little bit better to slightly draw it out of the sulcus. Turn this way. Scott's letting me know when I'm blocking your view, and I'm trying not to, but I know sometimes it will. Doing okay now? This one I block your view when I go back. Now we're to the canine. I'm stretching the cheek or the lip out. And staying in contact with the alveolar process. And just move very carefully. Some of this is a little tenacious. And you just want to make sure that there's no webbing. You get a little webbing effect. She's a great patient. I think it's probably because of SMU background. I think combination, living in Colorado, going to school at SMU, that's a hard combination to beat. Growing up in Colorado. I spent a lot of my summers as a youth in Colorado, age 10 on. Okay, so I've done basically an internal frenectomy with this frenum, so under. Just a little bit of a catch there, it felt like. There. You can feel it release, particularly if you pull the lip out. And just draw that little dimple right there. I want to be sure that that's not an attachment. Feels clear. I can pass that instrument under there. It's just an area that had a pretty good contact with some kind of little groove or something underneath. So we seem pretty patent. Make sure that this is good up here. So and we're good. Like, that's the length graft we took. So what I'm going to do, that's longer than from the molar to the central. That's a lot of palate. I don't want him to swallow it, but that's a pretty big graft. So that's the length of graft that we're using. And I will see if I can insert the graft through this premolar. And it's been soaking in the PRP, so it's going to look like it's alive. And we'll check the length. I like it. So we go from the molar through the central to the lateral, and it has good thickness. So I'm going to fold it on itself a little bit and see if I can insert it through the sulcus of the first premolar. Shannon's helping me. She has one curette, I have the one that's moving. And I'll try to get one corner under and then the other. And now we have it in. That's the key, is getting it started. Now it's a matter of feeding it in. It wants to turn on me a little bit, turn toward the posterior, which we need to go that way in a minute, but not this end, the other end. I can come through the canine and grab that, actually nudge it toward the anterior. Feed in a little bit more. come into the lateral. Let's see if I can nudge it along. And just do that gently, feed in it a little bit more. And now it's all the way through the central, which is where we need it to go. And what I'll do now is finish inserting it and back it up over the second premolar. Now, some people like to do that with suture, and that works too. It's okay to do it that way. I prefer doing it as I did. I think probably in this example, I couldn't have done it any faster with a suture. There's the end. So we know where it is. And that's where I'll start the suturing. You can see the end through the tissue here. So we'll start the suturing process now. So I just drop that corner under, and this gives you an example why I prefer to extend the graft. It's because I know I have a really good length of graft over the first premolar, which is the primary tooth. So I'm going to engage the pouch and the graft at the root line angle of the premolar, gently hit the tooth and glide out of the sulcus. And then I will pass the needle through the embrasure between the second premolar and molar. Capture that needle on the lingual aspect, not by the point, hopefully, because that will dull the point. And then I will put it back through the embrasure mesial to the premolar. So this is just like a sling suture around the premolar. And if I were doing an interrupted sling, I would now engage the pouch at the mesial of the premolar, go around and tie on the distal. But I'm going to go to the next tooth. I'm doing a continuous sling. I don't want to be on top of the papilla to displace it apically. I want to lift it. So I'm going under it. And that puts the needle in position to engage the pouch and the graft at the distal of the next tooth. So as I go from the posterior to the anterior, I'm engaging the pouch at the distal of each tooth. Now then, Shannon will pull that suture out of the way, and I'm going to put my finger where hers is and make sure that the graft is level with the pouch margin. Go through both at once. So I'm nudging it up so it's not displaced too low. You don't want the graft exposed, and you don't want it somewhere underneath the pouch margin. So you want it level with it. And draw that suture slowly. And now we'll go through the embrasure between the premolars. Shannon captures the needle for me, passes it back to the facial. Then I'll draw that slowly so it won't tie a knot. And then we snug it up as we go. If somebody is enjoying this so much, but they just think, gosh, I wish I could do it, come on up and I'll let you finish. This is, oh, it probably wouldn't, because this is really the fun part. Now under the papilla to get to the distal of the next tooth. And there was no recession here, but I still want to engage about 4 millimeters off the margin at the root line angle. It's not so critical to be at the root line angle where there is no recession, but where there is, it's absolutely essential. Now through the embrasure, Shannon captures the needle, passes it back. Need to go under the papilla now. And exit at the sulcus of the lateral, the one that had significant recession. Now draw that. Shannon keeps an eye on the tail. You don't want that tail to come out, but you want to maintain tension as you go, sort of like lacing running shoes or whatever. If you wait till you finish lacing, you can't tighten it. So maybe you could see that the graft is right at the margin of the overlying tissue. So they will both advance together, leaving little to no exposure to the graft. So I go through the embrasure, distal to the lateral. Shannon captures the needle, passes it back to me at the mesial of the lateral. And now I will pass the needle under the next papilla. Snug that up. And that looks so pretty that I'm going to have to take a break. It does. Root line angle. Distal of the central. Around the central, the left central. Exit in the midline. And go under the midline papilla. Snug that up. And this is 6-0 polypropylene suture with a C17 needle, if I didn't mention that. And now we're around the last tooth, right central. So I don't need to go under the papilla. We'll catch the distal of that last tooth because we cross the midline. It's the distal now. And start back. So I go through the embrasure, distal to the central. Shannon passes that back. And she's checking to be sure that the suture's below the cingulum. And under the papilla. Snug that. Then I'll pull the suture out of the way. I don't know if you've noticed or if we've mentioned it enough that you want to be really careful you don't cut the suture on these passes. So I'm pulling the suture toward the distal as I engage the tissue at the mesial. And the other thing, I'm grabbing the needle in the middle and I'm penetrating perpendicular to the surface. There's a lot of little features here to pay attention to. And now through the embrasure, Now we're looking pretty good. Thank you. How do you know I wanted you to do that?
I had a feeling.
Shannon, really good at reading my mind. So Shannon holds that suture out of the way. I've grasped the needle about in the middle. You can see that. And then we'll penetrate through pouch and graft, the mesial root line angle. Gently engage the tooth. You see where I'm exiting, so I missed that suture. It's a good place to see that. And then through the embrasure, around the tooth, and so on. Almost done. It's just a matter of paying attention to where you are so you go through the right spot. That sounds kind of silly, but it's pretty easy to get a little bit lost. So you pay attention. I think you see how nice that lateral looks that had the significant recession. I'll go under the papilla. Snug that up. And this suture is clean, doesn't attract bacteria, so it leaves no marks. As there's swelling, it kind of sinks into the tissue. And then stays there, so it's out of sight. Patients almost don't see it. Certainly not a concern. I think the propofol is starting to kick in. You getting sleepy? So go under the papilla between the canine and premolar. Shannon captures it for me. Thank you. And now this is the last tooth with significant recession. We have one more tooth to complete, but in terms of recession, this is the one. Shannon's going to pull that suture out of the way for me. And a couple other things of import to show you here in a moment. This is a place the suture can end up on top of the premolar. Open real wide, just a second. It can end up right across the middle of the tooth, and you won't see it sometimes because it's kind of small. So just make sure it drops into the sulcus. So now then I'll engage that at the distal root line angle through pouch and graft. Exit through the sulcus. Go around the premolar and we'll tie here in a moment. There's a point about tying as well. Now I'll come around the premolar. And then once again, make sure that it stays in the sulcus lingually and doesn't go across the lingual cusp. So now when you tie polypropylene, it's 3 throws clockwise, 1, 2, 3, and then you grab the suture end.
Probably my finger.
You're blocking. And just bring that down and tie gently. So you don't break the suture, gentle, it holds well. And then do 1 counterclockwise. Pick up that suture and don't bump into anything, lock it. And then 1 more clockwise. That one I don't think you need to do, that's for me, makes me more comfortable. And then Shannon will trim that and leave it about 6 millimeters long, because that way if they're swelling it won't get too short, it won't bother the patient, won't stick the patient so much. So we're going to do one last thing, and that's milk any pooling of blood from the base of that pouch, and I'm not getting much. Sometimes you do this and a lot will come out. You see there's just nothing in the anterior. Got a little bit of bleeding at the back, but almost nothing. And you can see the graft kind of glowing through the tissue. Not completely over here. The graft runs to about right there. And through the premolar. And we have complete root coverage in all areas, thickened tissue everywhere. So our last step is to add PRP to the surface. And this is just straight PRP, no calcium chloride, no bovine thrombin. And we'll just let that seep into the area at the margin. And we've soaked the graft in PRP to start with, and that's really all we need. And the procedure is completed.